Yeah, Connie, we do hear you now. I think you're good to go. And it's been the 2 minutes. So without further ado, please take it away.
All right, perfect. Well, thanks so much. And I'm really delighted to be sharing our work today on clinical implementation of AI tools to reduce disparities and increase access in peri-pandemic times. So it was in 2016 that I had the good fortune to meet Professor Regina Barzilay as we discussed how we could combine the strength of AI in the most pressing challenges we face in breast cancer detection and risk assessment and prevention. We had no idea in 2016 that we would be facing this pandemic in 2020. Had we known, I know we would have been even more engaged in rapidly addressing the challenges that we had to prepare for this pandemic. Breast cancer is truly spreading around the world. Out of more than 3 billion women, 2 million are diagnosed and 600,000 die every year. We know that effective prevention and detection strategies depend on accurate risk assessment models. In fact, much of our challenges in not being able to truly cure breast cancer have been based on the fact that we simply do not have accurate risk assessment models. There are very strong leaders in the field that created a roadmap for all of us that are studying in this area. Mitch Gale wrote a beautiful summary of 25 years of breast cancer risk models and their applications, clarifying for us both where we've been and where we need to go. And in his concluding statements, he strongly urged us to continue to work on these issues as much stronger risk factors must be discovered. He also has been very clear in identifying the challenges that we had, how many of our risk models were developed in white females being examined annually, how restricted that has been to not be able to predict risk across the full diversity of women who are subject to this horrible disease. Jack Cusick, also a leader in the field, believed that by incorporating mammographic breast density into the models, they could be improved. Despite 25 years of study, the best risk models available had AUC values of 0.6 to 0.63 to pushing 0.64, clearly not where we wanted to be. Adding mammographic breast density did increase the AUC values that were being reported for the most modern version of the Tyrer-Cusick model, which is version 8, to 0.65, but predominantly in white women. It made sense to incorporate mammographic breast density into risk models. This portrays information about the individual woman's breast tissue, and we know that breast density is an independent risk factor for breast cancer. Whether a woman has fatty breast tissue or scattered or increasing more complex methods of an extent of density or extremely dense, these were important factors that we wanted to consider. But it was so limited to only include a dense, non-dense binary factor when we have the complexity and the diversity of different mammographic patterns in every individual woman. In fact, what we thought was that our deep learning model could extract the full spectrum of signals embedded in the individual woman's mammogram. As a breast imager, every mammogram I see is like a thumbprint for the individual woman. I can tell if she's had a biopsy before, if that biopsy resulted in cancer or not, how her cancer was treated. Were her nodes dissected? Did she have radiation? Did her chemoprevention strategy effectively impact her background parenchymal density? These cues are ones that as a human, we can just scratch the surface on, but with the tools of AI, we can delve in and detect subtle cues that the human vision or the human brain couldn't begin to appreciate. And with this knowledge, we developed a large, quality, curated mammographic data set. We developed AI risk models to predict a woman's future risk, and we were able to compare them in our large Mass General database to traditional risk models. As expected, we found that the Tyrer-Cusick version 8 model performed significantly better than Tyrer-Cuzick version 7, version 8 incorporating mammographic breast density, and roughly the same as in the published models by the Tyrer-Cuzick group, with the caveat being that we had a more diverse population, which included both African American, Asian, and Hispanic women in the testing. Our image-only model, a model that only leveraged the data from the mammogram without the need for patient reproductive history, genetic history, family history, prior biopsy data, much of the data of which women are either unsure of or inaccurate in reporting. Our image-only first version model performs significantly better than the commercial models available. And our second version that was developed next, which incorporated new methods and new techniques of really leveraging the full strength of the image data, significantly improved over Tyrer-Cuzick version 8 in our Caucasian population, with the Tyrer-Cuzick version 8 model AUC being 0.64, our version 1 being 0.73, and version 2 image only being 0.75. But even more striking was how our model performed across races. In fact, Tyrer-Cuzick version 8 was just slightly better than chance in our Asian population, significantly improving with our AI image-only models, version 1 and version 2, to AUCs of 0.68 and 0.77. In African American and self-identified Black women, the Tyrer-Cuzick performed at 0.62 AUC versus 0.72 in our AI image-only model. I want to stress the increased feasibility of incorporating an image-only model. This leverages data from the image and doesn't require the extensive support needed to have accurate and more complex risk-based evaluation and assessment. So with this knowledge, we then rapidly moved into clinical implementation. All screening mammograms are automatically processed real time across all of our Mass General Hospital sites of practice. We have traditional and AI scores on all of our screening mammograms from 2015 to the present. Again, we didn't know when we were doing this how helpful this would be as we face the COVID-19 epidemic. So March 2020, for the first time in our history, screening mammography was put on hold as the healthcare system shifted resources that were seriously needed for the COVID-19 surge. Governor Baker and Ann Klebanski, as head of MGB, urged that we be thoughtful in how we address this urgent need to shift resources and also start to prepare and think forward to when we reopen. The impact was dramatic. Almost overnight, our weekly volumes, which had always been just under 1,000 screening mammograms a week at Mass General, the red line showing our 2019 volumes, dropped to only a few patients per week, 0 to 4 a week. And these were at high-risk patients that came in for their screening as they saw their doctors for other reasons. We canceled in a short period of time over 15,000 women's screening mammograms. This reduced access was due to many factors related to access to PPE, the required social distancing, and patient discomfort returning to healthcare facilities during the COVID pandemic. We know that screening matters. We know early detection matters. What would be the impact of our patients with significantly reduced screening? Many across and around the world were concerned about this. Ned Sharpless at the NCI modeled cumulative excess deaths from colorectal and breast cancers 2020 to 2030, and he urged caution, saying these are just preliminary early predictions that we have, and at this time, given the worsening impact of COVID-19, particularly in the US, we think these are serious underestimates of the impact. So the risk of missing early detection and annual mammography tests during lockdown being postponed or canceled, we've had a 94% drop in mammography imaging volumes. Providers are dealing with substantial growing backlogs as 100,000 screens are added every day in the US alone, and yet there's no processes in place to identify the patients that we should provide access to at this time. By late May 2020, in the state of Massachusetts, Governor Baker asked, looking at the evidence, being informed by scientists and healthcare practitioners and leaders in the field, to prepare for reopening of screening mammography access and urging risk-based screening. Ann Klebanski asked that, working as a true system, we expand our impact by getting more of our breakthrough ideas out in the world. And this really came to an alignment of the stars as we then implemented what our discoveries in AI had been to bring patients back in for screening. We were able to rapidly increase access and bring patients in using safety around PPE and social distancing, but we really wanted to be clear that this very large gap of patients we have not addressed. We have recovered to where we used to be pre-COVID, but we have not addressed the many thousands of women who opted out of their screening. It did give us the opportunity to compare how does this population of women who returned during the COVID-19 recovery period, how do they compare to women that routinely were being screened during normal times? We saw several significant shifts in the patients that we are screening now during this time of restricted access. We aren't seeing the same volumes of patients overall. We are still doing catch up to bring that trough of significant patients that weren't screened back in. We are seeing a higher percentage of white women and significantly reduced screening of women of color. And we are seeing a higher percentage of women being screened who are at risk by traditional models. But again, we know that the traditional models fall far short of our goals of identifying those women with cancer. So we then evaluated, how exactly are we doing with these different risk models? I want to spend some time on this graph. This shows our real world data from our clinical implementation time post-COVID. This was during the time from May, when we resumed screening of at-risk patients, through the end of July. If we look at our model of the percent that would be invited to screen and how many of the cancers in our population were detected, we can see that the NCI 5-year risk and the Tyrer-Cuzick 5-year risk fall short. I really want to clarify that neither the NCI nor the Tyrer-Cuzick were developed to assess risk in women with a personal history of breast cancer. Thus, we also model with our dashed lines here the impact of NCI and Tyrer-Cuzick 5-year risk models if we add in all patients with a personal history, assuming that they would be invited back during times of, quote, at-risk screening. The blue line represents our AI 5-year risk model. Our AI model evaluates women regardless of their history, whether they have a personal history or not, whether they have had prior biopsies showing high-risk lesions or not, and regardless of their age. There are various restrictions in the NCI and the Tyrer-Cuzick 5-year models. What we see is that if we were restricted, as we were, and as most centers across the country are, to screening a small percentage of patients, roughly 60 to 65% of normal volumes, and we used a cutoff of a 2% 5-year risk, we can identify over 90% of cancers within our population. That is significantly improved over the process we would be using if we used modified NCI 5-year at-risk models or Tyrer-Cuzick 5-year risk models, inviting those women at increased risk along with those at a personal history. I want to provide a cautionary tale. We are so excited and so engaged in the power of AI to improve healthcare, to identify with more precision those patients with breast cancer that need to continue to be screened during times of seriously limited resources. I also want to identify that we have always lived in, globally, a community with limited resources, but COVID-19 has forced us to look more carefully at how limited our resources are and how imperative it is that we have more precise methods of screening programs. My early career was focused on evaluating traditional methods of computer-aided detection, decades of research by many very intelligent groups developing CAD models. But through the Breast Cancer Surveillance Consortium, we were able to assess the impact of these models on real world performance across the diversity of mammography practices in the US. And we found despite a lot of promise, a lot of enthusiasm and excitement, we didn't see the impact on the sensitivity or the specificity or the overall performance of mammography using these systems. So at our center and with our work between MGH and MIT, we are really focused on the importance of effective strategies for clinical implementation. The promise is great, but we need to demonstrate real world clinical implementation, which is why we put so much work into this aspect of bench to bedside, from developing the models to implementing and evaluating them in the clinical setting. And in the end, the way that we will really improve our patient care is the multidisciplinary approach that we are taking that leverages the strengths from the domains of healthcare, computer science, and our regulatory bodies. We are so grateful for the combined expertise at MIT, at the J Clinic, at Mass General Brigham, engaged, excited people that really feel that we can make a difference when we work together. So thank you very much for your time, and I'll look forward to questions.
Thank you so much, Dr. Lehman, for the talk. I wanted to know if you could expand a bit about the workflows that MGH has been using since the restarting ramp up of mammographies to prioritize outgoing phone calls and scheduling for women predicted to be at high risk.
David, I'm sorry, can you just, I didn't hear you exactly. Are you asking for the process that we've had at MGH to identify these women at high risk?
Correct, yeah, the process that you used since the recent ramp up.
Yes, so we took those women that had been diverted from screening, we ranked them by their AI risk models, and we reached out to them, inviting them back in for screening. There are many, many determinants of who returns for screening. There were social determinants, as we identified. There were also patients that were coming back because their knowledge based on traditional risk factors, which is why we were able to compare all the different approaches, from the average risk women that returned because it was their desire to continue to be screened annually, from those that were identified by commercial risk models and those by our AI risk models.
A couple of follow-up questions about that. First, roughly what percentage of patients did you reach out to of the ones who had appointments canceled? I'm trying to get a sense of what fraction of that ranking, of the top ranking, was actually used in these outgoing phone calls.
So we identified 60% of the full volume of patients, but we've continued to go through to identify all the others. The model uses the prior mammogram risk factors, and we had the prior AI risk factor from prior mammograms on 75% of the patients that were in the queue.
And did it just use the most recent mammogram, or did it use a time series of previous mammograms as well?
We used any prior mammogram available from 2015 forward. So we went back to the most recent, but if they didn't have one in the prior year, we continued to go back until 2015 to identify that. And we're also working to see how that factors into the accuracy of the risk prediction.
Now, I've been hearing from many other clinical and operational leaders about the need in their areas for risk stratification to help figure out who to invite back, how to prioritize rescheduling. What lessons do you think are there to be learned for other clinical areas from your own work?
I think the most important lesson is the social determinants that can swamp all of our best, most scientific evidence-based approaches to effective and equitable healthcare. So we are delighted that our risk model is equally predictive across races. I am dismayed to see that we are screening more white women than women of color during these times. And those are social determinants, which we are working very hard on, and we need to be very focused on those domains. I also think it's going to be important that we focus a lot on acceptance, healthcare centers acceptance, patients acceptance. I always think that fear can have people not think clearly, and many people are fearful during pandemics, and many people can be fearful of computers, fearful of artificial intelligence, fearful of things that don't seem, quote, human. And so we have a lot of education we can do to have our referring providers, our healthcare systems, and our patients understand the information in ways that is comforting to them rather than instilling fear.
Dr. Lehman, thank you so much for joining us today.